Hello, everybody, and welcome to the Hughes Clues Hepatic Dysfunctions. This is part two. And when we left off, we were talking about diminished hepatocyte functioning and the problems that were associated in our patient subject when there was decreased or diminished hepatocyte function. Now let's talk about the other problem that occurs whenever there's hepatic cirrhosis or whenever there's cirrhosis of the liver. So really, what is cirrhosis of the liver? Well, it's damage of the liver cells. And if you think of cirrhosis, think of the highway, and if a car were to have an accident on the highway. And it's the same analogy with these liver cells. They become damaged, and so the anatomy of the liver itself is kind of changed. I've seen some fancy terms where it says the architecture of the hepatic cellular structure is changed. The bottom line is these hepatic cells, as they become damaged, the pathway changes, and what is supposed to happen is this is the portal vein that comes in bringing blood flow from all of the major abdominal organs. And then as the hepatic vein kind of puts its little fingers through the liver, then as the portal vein comes through, it's kind of like a finger. It spreads out, and then the hepatic vein connects with it. And so all blood flow is really supposed to zoom from the abdominal organs in through the portal vein and then connect with, like, consider the hepatic vein like another highway that it connects with, and then it goes back to through the inferior vena cava back to the right side of the heart. And the venous system is a very low pressure system. So what happens is whenever there is cirrhosis and damage of these liver cells, then there becomes this huge resistance to blood flow. So there is no longer the zooming through the portal vein. There is a lot of back pressure that develops because the blood cannot zoom through the liver, and that increases the pressure inside that portal vein, and it's known as portal hypertension. And what happens is, just like on the highway, whenever there's an accident in one space, so consider that your hepatic cells are the accident, then this back pressure occurs, and that increase in venous pressure in the portal system causes the development of problems in these other abdominal organs. And one of the complications is that with that huge venous back pressure, it will cause leakage of fluid from the portal vein into the cells in the abdominal cavity, and that is what causes ascites, or that is one cause of ascites. So what is the potential problem with hypertension, or portal hypertension, is that, of course, you're going to have leakage of fluid. That's going to cause water to leak from the venous system into the cells, so that's that third spacing. And so you have all of these problems that we've really already addressed with the huge belly. Now, the increased back pressure also causes the formation of varices, and what varices are is their vein dilation. And so it's essentially, if you put a lot of water in a balloon, well, it's going to kind of extend that, make the balloon stretch, and that's what's happening. You've got all this back pressure in the venous system that is not used to a high pressure, and therefore that causes the ballooning of the venous blood vessels, the smaller venous blood vessels in the esophagus, stomach, and anus. Now, you've already identified what are the treatment potentials, and we've already talked about managing the fluid volumes and the assessment of the respiratory center and the draining of the fluid with paracentesis. But we also have to consider the control of that portal hypertension, because if portal hypertension is the cause of the problems, well, then we need to try and reduce this venous pressure, and that is done through the use of propranolol, a beta blocker. Now, what does a beta blocker do? Well, it decreases the cardiac output. It blocks the beta cell, which causes a rise in heart rate and a increased force of contraction in the heart. And if you have propranolol on board, then the heart rate will decrease and the force of the cardiac contraction will decrease. That will decrease the cardiac output. And so the thought is that hypertension, portal hypertension, venous back pressure will reduce. Now, if there is continued problems, as in the propranolol doesn't control the portal hypertension well enough, and this patient is undergoing frequent paracentesis procedures because of the fluid collection inside the abdominal area, then they can do kind of a more permanent treatment, and that's called TIPS, transjugular intrahepatic portosystemic shunt. And TIPS, essentially what it does is it's going to create new connections between blood vessels and the liver, and then the whole purpose of it is to reduce portal hypertension. The procedure is done in interventional radiology. It's conscious sedation. The patient's going to have to be NPO, and then I've given you a description of essentially what the procedure is. It's just a rerouting of blood flow to kind of ease up on that portal hypertension. And the TIPS is effective, of course, in reducing the portal hypertension and decreasing sodium retention and improving renal response to diuretic therapy, because if you don't have a lot of third spacing, fluid leaving the vascular space, well, then the kidneys are going to be a lot happier because they're going to get better blood flow and they'll work better in the long run. So, this is a very effective procedure, but it's always show me the money. It comes down to the cost, and it's going to be a higher cost versus perhaps frequent paracentesis procedures. So, patients who have less access to health care because they don't have private insurance and they're reliant on either they don't have any insurance or they're reliant on the governmental assistance, so that's going to be a consideration. We're going to go back to our patient and the problems that are associated with portal hypertension. What happens, again, if you have a non-compliant patient that doesn't present to the healthcare facilities because of lack of health resources or just because they're sick and tired of being in the healthcare facilities. And so if portal increase or if portal hypertension continues or it increases, you've got that increased venous back pressure, vascular congestion back into the abdominal organs, and it affects the esophagus and the stomach with the esophageal varices. And these varices become enlarged, they swell, and they can very easily bleed. So what I've got here on the right-hand side of the screen, you see a picture of these swollen esophageal varices. These are all the venous blood vessels that's in the esophagus, and then should one of them pop, then you're going to have a fairly dramatic blood problem. So here are bleeding problems. So here we've got esophageal varices, that's the problem, and any increase in abdominal pressure. If you think back to what our scenario read, this individual has got chronic bronchitis. She's probably frequently coughing, and any time an individual is coughing or they're sneezing or they're bearing down with that Valsalva maneuver, it can cause even more pressure and those varices can pop. So you have to assess the patient for anemia. Again, the signs and symptoms of anemia. These individuals, if they do ooze and bleed from their esophageal varices, there's two ways that blood is going to move. It's either going to slither down and just kind of collect in the stomach, and then it can slither on through the GI tract. That's why they get the dark bloody stools. Or sometimes bleeding in the stomach, as it gets slightly digested, it can cause nausea, and these patients will vomit the coffee ground emesis, that's the partially digested blood, or it could be frank bleeding. Again, more vomiting can cause more bleeding because of the pressure. And when we talk about the treatment of bleeding, we want to prevent bleeding from occurring. That's with the Enderol, so that prevents bleeding. But once bleeding stops, now we have to use maneuvers or measures to also stop the bleeding, and we'll go through that in just a minute. We're still on problems. I know this seems like this is forevermore not finishing, but we've identified in our patient that she had a decreased platelet count. So what's the connection with the decreased platelet count? We get that the low hemoglobin is going to be from those bleeding varices that are either in the esophagus or the stomach, but why would the platelet count be down? Well, again, we go back to the portal hypertension, that elevated venous pressure, and that causes backward vascular congestion. And we talked about that congestion causing the varices, but the other thing it can cause is blood is also, as it flows, is supposed to zoom through the spleen. And then as it zooms through the spleen, all of the blood cells are cleaned by the spleen. That's the spleen's job. And then if there's an old blood cell that's supposed to be kind of removed from the system because it's old and not doing its job, then the spleen does that too. So I always think of the spleen as a blender. It's essentially blood cells, all blood cells are kind of churning around in the spleen. They're getting cleaned up or they're getting destroyed, and then it's supposed to move out of the spleen and move through other parts of the body. And whenever there is increased portal hypertension or back pressure, then what happens is those cells get trapped in the spleen. It's called sequestration of blood cells, and they become trapped, and because it's a blender and it's always kind of spinning, then these cells will ultimately get destroyed. And therefore, there is a reduction in all blood cells. So there's a reduction in the white blood cells, the red blood cells, and the platelets. And that term is pancytopenia, when all blood cells are reduced. And it's unlikely Dr. Reed will test you on that, but all of this vocabulary is fodder for either ATI or NCLEX. So let me just throw out some more vocab words. So let's talk about the problems that can occur from splenomegaly. All blood cell types are reduced. That's pancytopenia. And then I've given you the signs and symptoms of some of the things that can occur because of splenomegaly. I do want to point out that with a diminished red blood cell count and the a diminished white blood cell count, and the diminished ability of the liver function, the Kupffer cells in the liver that are also responsible for fighting infection, you add those two things together, and patients with liver disease are extremely at risk for infection. So you have to, as a nurse, you have to ensure that their immunizations are up to date. When we have bleeding esophageal varices, we're kind of jumping around because there's so many problems, but we've talked about this patient's problem that the hemoglobin was down, and so it's likely that she has a GI bleeding from somewhere. Quite frequently, they're bleeding esophageal varices, so we use propranolol or Enderol or a beta blocker to prevent bleeding. But now, once the bleeding occurs in these varices, then we have to do measures to stop the bleeding. So what do we do, or what does the healthcare team do to stop the bleeding once it occurs? So patients will be given fresh frozen plasma. Remember, all blood cells are diminished because of the splenomegaly, so they'll need platelets, they'll need red blood cells, they may need clotting factors because of the loss of clotting factors from the bleeding. We're going to look, or the physicians are going to order endoscopic exams. Either they're going to go from the top down, that's an endoscopy, or from the bottom up, a colonoscopy. And if there is bleeding, then the patient is likely, and the source is suspected from esophageal varices, then it is likely that while we're waiting for the GI lab personnel to do or be there to take the patient for an endoscopic examination, IV vasopressin is going to give. So what is IV vasopressin? How does it work? What are the precautions that are needed when a patient is on vasopressin? So vasopressin is a vasoconstrictor, just like the sound of the name vasopressin, vasopressor. It's a vasoconstrictor, but it also decreases portal blood flow, and so it will also help with portal hypertension. Here's the problem. It has systemic vasoconstriction effects. So if you have a patient who has also a comorbid condition, such as coronary artery disease or some kind of cardiac problem, then it can also decrease or vasoconstrict the coronary arteries. And this can cause not only a rise in systemic blood pressure that increases the workload of the heart, but it can decrease the blood flow in the coronary artery, which will decrease the blood flow to the myocardial, the muscle of the heart, and this can cause patients to have chest pain. And so if there is a suspicion of myocardial ischemia, the nitroglycerin is sometimes given. So this is frequently a test question because there's so many complications or adverse responses to the administration of vasopressin. However, again, your patient, we don't want them to bleed to death, and so we have to do vasoconstriction. It's always a very fine risk or balance of determining is this a risk or a benefit. So what happens if vasopressin doesn't treat the bleeding and it doesn't stop? Well, again, the patients are taken to the GI lab, and they can have several different procedures that can be done there. And one during the procedure is what's known as esophageal banding. So again, when you look here, this is a picture of the esophagus. You can see how these varices are massively dilated in the esophagus, and this one is bleeding. And so what can the physician can put, it almost looks like a rubber band, and just put a rubber band around that of varice, and that is one way to stop the bleeding. The patient returns from the GI lab. She complains of nausea and vomiting. She vomits a second time, and this time her vomit contains frank red blood. So in other words, the procedure in the cath lab didn't cut it. It didn't completely stop all the bleeding. She is still bleeding from her esophageal varices. So now, what are the treatment priorities as she vomits? And of course, it's always about airway. If she had conscious sedation in the cath lab, she's increased risk. But we always have to ensure an airway, assess the vital signs, and let the physician know that not only is the patient vomiting, but she's also still bleeding. And so when the treatments, the more conservative treatments, such as the esophageal banding, or if the TIPS procedure didn't work to decrease portal hypertension, so now what do we do for this patient? She's on vasopressin. So then the decision can be to insert what's known as a Sain-Steken-Blakemore tube. So what is that and how does it help? So when we look at this tube, it's a fairly impressive, massive looking tube. It is inserted through the nose or through the mouth, just like any oral gastric tube, and that's really kind of what it looks like, is an oral gastric or nasogastric tube plus these massive looking balloon things here, and then you see 3 ports. So the tube, most commonly it goes in through the mouth because it's fairly big. There is less irritation in the nose and further bleeding from the trauma of inserting a tube, but it can go in through the mouth or the nose, and then it goes down through the esophagus. And once it's in place, once there is somewhat confirmation that the tube end is in the stomach, then that's when these balloons are inflated. And these balloons are very large, and so they require a lot of air plus fluid. Usually there is some solution that's inserted. And then these balloons are inflated to a certain millimeters of mercury. And essentially what the balloon does is tamponade or compress on those bleeding esophageal varices. Now, the balloon that's in the gastric has twofold purpose. One, it keeps this esophageal portion of the balloon, of the catheter, in the esophagus so that it's doing what it's supposed to do, compressing on the varices. So it's like an anchor that keeps the balloon in place, but it also, if there are stomach or gastric varices, then this gastric balloon can also compress on those. Now the problem can be that if for some reason there is a leakage out of the gastric balloon and it kind of deflates, then this balloon can shift, which can cause airway occlusion. And because there is so much air and fluid that is put in this tube, we usually have a pair of scissors at the bedside so that we can just cut it if we need to remove it quickly. These individuals are fairly impressive looking because they'll have a football helmet on because we really don't want this balloon to slip, and so they'll kind of wrap the end of the balloon around the football helmet. I don't know what those things are called, but the little bars that correct that help the face or protect the face from injury during football. Now, this is something that in the early 80s I would see somewhat frequently when I was first a new nurse, and then I didn't really see it for a lot of years, but in some recent rotations with students, I've actually seen it. And I have students at Baylor University Medical Center, which is a liver transplant center. And so these individuals that are at Baylor and any transplant center are very, very sick. And once they start bleeding, they really do bleed a lot. And so I have seen kind of a resurgence of the use of this tube. So I sure hope that you get an opportunity to see it because it is a learning opportunity. This concludes the portion of the hepatic dysfunction problems, patho of hepatic dysfunction and portal hypertension. If you have any questions, email me, and then look forward